we received a ton more training. And if I look at the things that we knew prior to COVID related to infection control and the things that we have learned since then, you know, we really grew out of, I'll speak for myself. I won't speak for these folks, or for Joe. It grew from infancy. I mean, I know so much more about infection control now because of that. Plus, the other thing is there are so many requirements around infection control that there's a lot of different ways to receive a citation for non-compliance. The other area that is across the board with the state, the region, and the nation is accidents. Accident hazards, the typical types of things that are being cited are supervision. So your folks that are wandering or eloping, it's fall precautions, it is smoking. I know a lot of facilities have gone non-smoking, but we do still see issues with smoking and supervision related to the smoking, safety during smoking. And one of the potential outcomes there, and I'll talk about that just in 1 second, is we've had a number of immediate jeopardy situations because of smoking. Another common area is kitchen. Again, the issue with kitchen, a lot of requirements. Therefore, there are possibilities there that citations can occur. Then things get a little bit different, right? But when you look at the top 10 or 12 citations, you're going to see the same things across the nation, the region, and the state. And you're seeing things like non-pressure related skin conditions, care plan revision, medication storage, and significant medication errors, abuse. You know, and we've had so many conversations about abuse that it's a really, you know, if it happened, you have to cite it, right? So we try to figure out what it is. And that's really the only flexibility we have when you look at the situation, particularly a resident type of an incident. And the other thing that jumps off is, for me as well, is ADL care for dependent residents. That is commonly cited across the nation, and is certainly something that we've been citing in Colorado as well. Did want to let you know that we had 18 immediate jeopardy situations the last federal fiscal year. And so resident to resident altercations, staff to resident altercation, non-pressure related skin conditions, suicide and suicidal talk, and taking that seriously. We had an immediate jeopardy situation that pertained to an incident there. Elopement, smoking again, right? And then making sure that staff are available, that are knowledgeable of your evacuation procedures and the risk that unknowledgeable staff might present in the event of an actual emergency. Yeah, and then pressure wounds. We almost got through the entire this federal fiscal year without having an immediate jeopardy situation related to pressure wounds. And unfortunately, towards the end of this last federal fiscal year, we had 3 situations where there was a very severe facility acquired avoidable pressure wounds. So that's what I have for you, other than just to put a little plug that should make sure that you have been involved in the development of the enhanced facility assessment in your communities, because that is a requirement. That's what I have. Thank you.
Thank you, Chad. Really appreciate your updates. Jenny Albertson with CHCA.
And do you have my slides?
We do.
Okay.
Hold on.
Say a little prayer.
That's awesome.
Hold on.
Okay.
Yes.
All right. Well, we're not quite there yet, but we're very close.
Thank you, thank you.
I can be your page turner or you
Oh, I can do
can.
it. Yeah, great. Thanks so much.
Thank you.
All right, so I'm gonna go not into the regulatory realm because I don't have to today. Thank you, Chad. Appreciate it. All right, so we're gonna talk about random things, as is my habit. Hopefully I can get this. Oh, like this.
Oh,
Let me see.
PDF, you did, oh, we have the
Hmm.
PowerPoint too, if you want to do that.
Okay, we can do it this way. It doesn't matter.
It's okay, I had two versions.
I thought mine was.
Okay, I did want to update on some announcements from the IP team at the department, since we didn't cover this piece. The infection preventionist training course, you might be talking about this a little bit, but the co-trained platform did update on July 31st. And so if your folks have not done their annual am I up to date inspection, self-inspection, they should probably check that out and either retake it just for the sake of understanding what's there, or at least validate that their other types of credentials, which you'll see listed here, and the slides are all linked on the agenda, meet the regulatory requirement under the local mitigation guidance for CDPHE. And just a quick note on that, the only variation that we have from CDC's guidance as far as COVID mitigation strategies is that we have that requirement for holding a vaccine clinic within 60 days of having a new vaccine approved. That's our only oddballness in Colorado. I've asked for them to de-oddball us if they would, please. But I don't know if that's really going to happen in the coming future. They were wanting CDC to update their information with the respiratory guidance and do the trainings that they were doing with the new season coming out, and hoping that CDC might make some changes themselves, and then they could make all the changes at once. Since there weren't really any changes for long-term care, they may still proceed with doing that. So stay tuned on that one. Dr. Gong may have more information on that. I don't know who you've been talking to, but I'm keeping my ears open. Yes.
Is it the date that the FDA approves the new vaccines for 2024? Or is it the date that the ACIP decides who is eligible and how should we do it? Which date do we do the 60 days after?
I could give you an answer, it would be a guess.
It's
So
the
I-
FDA approval.
Is it?
That's what's in the actual mitigation guidance. Yeah.
Because sometimes that's hard, because sometimes the ACIP waits and then, and then it takes them a while to get access to the vaccine. So 60 days sometimes is rough, just saying. Thank you.
Yeah, and hopefully we're not seeing as many hiccups with getting collaboration now that we've done this a few times with pharmacies, but the billing nightmare is, of course, still a nightmare. Other change on the IP and COVID piece, we are going into the season, right? So let's just get this out of the way. CDPHE is going to eventually transition back to local public health for managing outbreaks. And that process starts today, October 1st, and goes all the way to May 2025. Freaking me out a little bit because, we all experienced the chaos of the cowboy mentality at local public health when we were dealing with outbreaks at the very beginning, but that was before we knew anything, right? Let's just hope we learned. So hopefully our enforcement and all of that will be in line in terms of when to clear and all of that sort of thing. They are doing their best to kind of coax along the local public health and transition smoothly. It's voluntary for them until May 2025. This article came out and I thought it was of particular interest because our elders are not adequately represented in the use of the BMI. Everybody's nodding. This is such focus. I mean, or anybody who's been to a doctor's office. Morbid obesity. Right? The BMI is not an accurate capture of distribution of weight and actual morbidity mortality risk. We've known this for a long time, but there's been a void of something better, right? And so it's kind of built into our CMS surveyor guidance, but to use BMI, we end up seeing it go to IDR, informal dispute resolution, to get tags dismissed because we didn't feel that we were inadequately treating someone's nutritional needs, but BMI was kind of the only way of gauging whether they had nutritional needs. So somebody a mathematician came up with a different idea, and that is the body roundness index, the BRI. It hit the New York Times, and there's actual studies out that are kind of supporting this concept. about how where you are round influences your risk for cardiac and all the correlating studies to that. So I'm guessing that this will not be standardized for quite some time, but my thought is if we decide that we want to use other indicators for nutritional deficiency and we want to back that up with QAPI, with a policy procedure, maybe not the BRI, maybe the BRI, I don't know if it'll be adequately supported out there, but the world is changing and it might be better in terms of person-centered, person-directed care to use something other than BMI moving forward. The world is opening to the idea is what I wanted to bring to your attention. This is just a note of cheer because why the heck not? It's good news. We are seeing some improvement in our workforce climate. So the Great Resignation and all of that was a little more exacerbated in the world of healthcare, in case you didn't notice. And people were reporting in these studies that were out there, these surveys, that they had thought about leaving the career and were on their way out quickly. Those numbers have improved. So it may not seem great that 36.7% of respondents say they've seriously considered leaving their jobs because it's over a third, but hey, it's better than half. So I'm counting that a victory and we will hopefully see that it continue to improve. And then the leadership piece, which I think we all would agree is a disaster when it leaves a building. We see a decline in profitability and consistency of quality outcomes. Your relationship as a medical director gets out the window, you got to form a new one. But leaders are now at 76% satisfied. And the biggest bump was in administrators, which was a 10% satisfaction increase. So that's huge. I think some of that is in no small part due to some of the ownership groups. I don't know if you follow the profession as an industry, so to speak, but one of the largest nationwide ownership groups now is PACs, and some of you work with PACs. They tend to pay a substantial amount more for their administrators. That's one of their retention strategies. We're talking double in many cases what they pay an administrator in some of the other companies. That inherently is going to make it much harder to justify leaving a position. So anyway, all right. And last but not least, NHSN is changing the COVID vaccination compliance and starting to incorporate into the QF. So just if you need to look for a new up-to-date definition, it's basically what we expect it to be. It's the new vaccine and you're unvaccinated until you have the new one. So when they're reporting, that's what they're expecting. And I posted this as a resource for you if you want to look at respiratory virus risk for internal decisions about when to universally mask. This is where you can look on CDC's respiratory illness data. And a quick note about flu mist being approved for self-administration next year. Do I have another minute more?
Oh,
yeah. Sure. Okay. We wanted to get to this piece. CMS is changing quality reporting data. And this is like your MDSs. They roll on up to CMS and from that, they tease out quality measures, not just the quality measures, but actually quality reporting data that impacts our Medicare reimbursement. And they've added some additional elements to this because they want to sort of broaden the scope of what we determine to be a gauge of quality. It's not just pressure ulcers. It's not just weight loss. Now we're trying to look at like social determinants of health. And that's going to add in 2027. And there's a 2 percentage point if SNFs do not meet their reporting requirements now before all these things get rolled out. So they're starting with the stick, no surprise, welcome to CMS. And they're enforcing this 2% reduction in reimbursement if people don't report. And then they're adding the juicy stuff in 2027. So that'll be living situation, access to food at home, utility disruptions, transportation has already been on there. So know that we're taking a little bit more of a big picture, whole person, soft science approach with our MDS data gathering moving forward. So kind of more in tune with how we might see our patient care, a little scary in terms of how we capture some soft data. So we'll see how it comes to fruition. And then this talks to you more about how they're adjusting the QMs. Discharge function score is replacing the function outcome for ADL function. So they want to know, did you actually discharge someone after a skilled stay appropriately? That's what they're gauging now instead of just, are they functional in an ADL kind of way? And that's the numerator denominator and the exclusions for your reference. Okay. And then our events. Today I'm hosting right after this pay for performance seminar, and then tomorrow at our offices is a meaningful care plan seminar from Ruth Minima. So thank you.
Thanks.
So much, Jenny. Moving along, our next update is coming from Courtney Ryan with Telligen.
Hi, everyone. Good afternoon. Normally, my amazing peer Mariah gives the updates
Oh.
for our QIO, but I get to be here with you in person today, so I'm really excited and to see some familiar faces and meet new faces too. So hold on. Sure. So over the next couple of minutes, I'll try to talk fast because I think I have 5 minutes. I'm going to give some updates around the support that our nursing home team has been providing to nursing homes in the space of high-risk medications and what that looks like at the facility level and the resident level.
Hold on, I'm almost there.
You are doing it. Thank you. I like the back of my head is on the camera, so sorry. Or to you. Thank you.
I'm gonna be really fast.
You are doing great.
And you should be able to just use this.
Oh, just the down arrow.
Nope, this one.
Oh, the side arrow. Okay.
I can just do it for you.
Okay. So the first one is just kind of a not so fun fact, but did you know that 1 in 3 nursing home residents experience adverse events related to medication, according to a study that was done back in 2022 by the World Health Organization? So I don't know if that number seems high to you all or low, or if that seems about normal. That seems really high to me. So I thought that was kind of interesting. Thank you.
Okay.
So there are federal tags associated with high-risk medications. These are just a few of them. There's certainly a lot more depending on the situation or the scenario.
Right.
But these are the ones that we typically see
And,
under the regulatory
let's see.
group for pharmacy services. So you can see that there are
More.
7 of them listed here. The 4 that are notated in red are those that would indicate a substandard quality of care. And so part of the support that we've been providing in helping nursing homes just kind of get ready for survey is to help provide education around what these tags are and what is included in them, as well as always encouraging nursing homes to use the critical element pathway tools, which come from CMS, which are kind of like a checklist for surveyors when they're coming in and looking at different departments and programs. And so just making sure that they're aware of those, going through those and finding any gaps in any processes.
Okay, well, I'm in the middle of.
Another
the
part of the support is
orders now
looking
for
at their data and taking a closer
about
look at
a
that.
half
And so
hour.
we start with just having some conversations
Okay.
around, are you tracking residents on high-risk medications? And if so, what does that look like?
All right,
Do you track unplanned transfers? And again, if so, what does that look like?
Okay.
When a
Okay.
resident on a high-risk medication has an unplanned transfer, do you review for signs and symptoms for a change of condition prior to that transfer? And what do some of those processes look like? And then just inquiring about other data that they might have available to them and helping them navigate through that. No. Did it change?
Oh,
Okay. So as an example of some of that data that we might provide for them, just to help add some depth and context to that conversation, this data comes from MDS resident assessment data. So it's publicly available, although it's kind of difficult to data mine and put down into some sort of user-friendly visual that we can actually do something with it. And so here's an example of some Colorado specific data. This is the percent of resident assessments with a high-risk medication taken. And so you can see, for example, here we have around 46.8% of residents on an antidepressant, 32.5 on an opioid, and then you can see how this goes on down to 1.4 on a hypnotic for the time period taken for this MDS assessment data. Thank you. Here's another example of some data that we provide. So this is similar to the graph that we just showed before, but this is at a facility level. So this allows the facility to kind of get that bird's eye view of what this looks like in their building. So for this example, for this facility, which has been de-identified, there's 41.3% of their residents on an antidepressant, followed by a diuretic. And then it looks like around 28% are on antibiotics and so on. Next slide. We're also able, just based on the MDS data, to look at the percent of resident assessments with a high-risk medication taken and documentation indicating medical necessity. So in this area, we would want to be at 100% for all of these, meaning that for every single resident assessment, it's also, there's indication noted for that medical necessity. And so here we might look at MDS processes, the coding processes, medication review, some of those kind of things. But this gives them just another idea or another lens to look at some data from. Thank you. And then I know this is really busy, but again, just another visual for some data that we're able to provide. So this has also been de-identified here in the gray box with resident information. But if you start on the left-hand side, you can see that we can drill down at the resident level to see how many high-risk medications they're taking. Again, if that indication has been noted. In the middle there's some codes there that pertain to admission and discharge dates and unplanned transfers and things like that. So we can dive deeper into some of those areas. And then on the right, it would indicate the different types or classification of the high-risk medication that they're taking, and the indication is noted so that we can just really drill down into some of the quality improvement projects that we're working on. Slide. And so with all of that, some of the potential opportunities that we've been exploring, again, are looking around processes for coding, medication review, different options that they're using for alternative interventions, their processes for gradual dose reduction. And then this is just a screenshot of where we get that data from the MDS assessment itself from section N0415. So all of that has been helping us with different projects around QAPI, around falls, adverse drug events, unplanned transfers, ED utilization, all of those kind of things. Thank you. And I think that's probably at my 5 minutes, but it's really been awesome work. So if you have any questions, I'm here. My team is also on the call too. So track me down and I can see if we can help you. So thank you.
So much, Courtney. Thank you, Jenny, and thank you, Chad. We'll appreciate all of your updates and helping us all do better with our work. Our next speaker is Dr. Cari Levy. This talk that's coming up, the psychedelic-assisted therapy, is it an effective treatment for depression and anxiety in older adults? This topic has actually been waiting in the wings for several months. We wanted to hear it for so long. So we're finally glad to have it on our agenda today. And Dr. Cari Levy, if you're not familiar, she is the chief of the Division of Geriatrics at University of Colorado.
And I see we have some fellows on the line, so that's exciting.
Oh, good.
Yeah.
Thank you for joining us, fellows.
Indeed.
Yeah.
So today is actually kind of the perfect day, Sam, to present this because today, maybe our health department colleagues know more, but it's the day it goes live. I think October 1 was the day that the law in Colorado allowing for psychedelic assisted therapy becomes effective. I think there's still some work being done on regulating healing centers and that kind of thing. But today, I think, was the day it was supposed to be enacted. So Colorado, well, we'll hear more, but basically, yes, we're going to talk about psychedelic assisted therapy, and we'll start with just because we're sort of limited on time, and I don't think that clock is accurate. It is. Oh, it is. It is. Okay, great. Your computer's fast. So I'll just ask you to think, and you don't have to share, but just what comes to mind initially when you think about psychedelics, and just tuck that away, and then we can talk when we finish talking here, if anything changed in terms of your thoughts about psychedelics. I personally, when the cannabis, stuff was being regulated, thought, I'm a palliative care doc, and it's not like people are coming saying, I need cannabis, I need it now, why are we doing this? And since, we've all learned more about cannabis and where it might be helpful and where it causes trouble and things. And I think the same will be true of psychedelics over time. We'll learn where it might have some benefits and where we might get into trouble. But my hope is to just familiarize yourselves or familiarize you all with sort of the research behind it and what we might expect in Colorado in the months to come. So the case presentation today is an 82-year-old male who presents with severe treatment-resistant depression, and he read about psychedelics in Newsweek, and he comes to you wondering if it would be safe and worth a try. He's in your facility for functional limitations related to a fall and a fracture of his leg. You can see his cast there. And this is requiring an extended course of antibiotics and physical therapy, and he's feeling pretty low. So what did he see in Newsweek? He saw this cover, which is a new treatment for depression, and they've got some cute little mushrooms that also kind of look like bones.
Yeah.
They're mushrooms. And so what we're going to talk about is just risks and potential benefits, mechanisms of action, which are fascinating, and some of the evidence that's coming out, and then whether it pertains to our population. Okay, so classic psychedelics, things like psilocybin, LSD, DMT, are tryptamines, phenylethylamines are mescaline, MDA, some of these other psychedelics that you may have heard of. And the idea is that they produce a unique change in our thoughts and our emotions. I'm so sorry I have my book to you. So how do they work? And they work on things we're really familiar and comfortable with, things like dopamine, norepinephrine, serotonin. And serotonin is the one I'm going to kind of focus on because that's where some of the data would suggest a lot of the effect comes from. So next slide. You'll see here a very familiar presynaptic neuron that you saw in your studies at some point in your training. And you can see sertraline here, which would facilitate, or enhance reuptake. We've got serotonin uptake, serotonin, what am I trying to say? Reuptake inhibitors, right? So we have medications that affect the 5-HT receptors, and psilocybin is not so different. It works on those same receptors, at least one of its mechanisms of action. And so what you see here are actually all the different psychedelics. You can see LSD at the top, you can see psilocybin over here on the left, and it's working on those receptors we're pretty used to thinking about, 5-HT2A, 5-HT1A, 5-HT2C. This is where a lot of our antidepressants, what they target. And then you'll see down here, MDMA works more on some of the reuptake of cortisol and vasopressin and oxytocin. Ketamine's up here in this corner, slightly different mechanism of action, but psilocybin not so different from many of the antidepressants that we prescribe. So is it legal? Well, in Colorado, as of today, the answer is, I believe, yes, because the Colorado law allows for healing centers. And these healing centers are where you can have psychedelic-assisted therapy. And it can come in the form of a tea or an edible or a tablet or a tincture. And it cannot be sold in a dispensary. So I think one of my worries when this got legalized was, oh, geez, now we're going to have a, marijuana dispensary next to a psychedelic, mushroom place. And we're just going to have a whole new environment here. But that is not going to be the case, at least how the law is written now. It cannot be sold in a dispensary and is only supplied at a healing center. And I believe it's illegal to sell it. And so it's part of the therapeutic process to receive it. They're not selling you the mushrooms, they're selling you the psychedelic-assisted therapy. So it's federally illegal, much like marijuana. And they're waiting on phase 3 clinical trials to reclassify it. But as of now, it is a federally illegal drug. And there are a couple of companies that have been designated as breakthrough destination treatment. And so we'll see what comes of those studies, and we'll talk about a few of the other studies today. So this is the law, is Proposition 122, and it allows access to natural psychedelic substances. And so by 2024, which is where we are now, supervised use of psychedelic mushrooms is authorized for people over age 21 at licensed facilities with state-imposed regulations. And my sense is that these are still sort of being developed. If any of you all know anything, please chime in. But they're still being developed, and the idea is that there will be some expectations for these facilities to tell us how they're receiving the mushrooms, how they're disposing of the mushrooms, and have some standards in place. They have to go through, I think it's 120 hours of training or some amount of training. So there will be some requirements. But the law decriminalizes possession, growing, sharing, and use, but not sale again, by adults. So you can go to these healing centers, you can have the psychedelic-assisted therapy, receive your tea or tincture, and all of that will be legal in Colorado. So right now it's a Schedule I compound that has no medical use, so that's why it's federally illegal. And interestingly, the National Institute on Drug Abuse says that they do not consider, oh, sorry, that's a typo, it should be say does not consider psilocybin and other classic psychedelics to be drugs of addiction because they don't tend to cause compulsive or drug-seeking behavior. Medical emergencies are very rare, kind of like with cannabis, what we learned there. It's very, very hard to overdose on cannabis. Things can happen, of course, but medical emergencies are rare. There is concern for exposure due to potential panic reactions. And in some cases, much like with our cannabis experience, people might run out in the street because they're feeling panicked or have some sort of behavior that might cause trouble. So in a survey of persons who had challenging experiences with psilocybin, 11% of them said that they placed themselves or others at risk of physical harm, and 10% reported that they had enduring psychological symptoms that lasted greater than a year. So I include those to say it's not without risk, right? There are a lot of people who will say, hey, fantastic, and no problems. Well, there are. Most people do fine, but some people don't. And so that's what I wanted to emphasize here. So the biological mechanism of action is fascinating. The idea is that you have these damaged neural networks and that they're repaired by briefly destabilizing the connection. And it's like if you were to press a Control-Alt-Delete button on your computer, and it kind of just resets everything. And the thing that you'll hear talked about with psychedelics is the default mode network. And this is thinking about yourself. You know, your brain has a way of focusing something. Let's say you're focusing on a discussion right now. So other parts of your brain just turn off so that you can focus on the lecture. But what happens, or the theory of what happens, is that that default mode changes with psilocybin, and that you are no longer hampered by the fact that your brain wants to focus on one thing and you can focus on everything. So that's kind of the idea. And so, it has to do with altered thalamic gating is the thought, and that overload in the cortex actually increases sensory perception. And then there's this relaxed beliefs under psychedelics theory where there's a disruption in the hierarchical nature of the brain. So instead of kind of going through the hierarchical, you know, oh, I need to pay attention to this before that, you have less of that and everything kind of gets equal attention. There's also this cortical claustrocortical model, which says that, that these dense cortical networks are disrupted. And this becomes important in some of the research because what they're measuring are the number of connections, the number of dendrites that you see connecting after this type of experience. So it's also thought to potentially be anti-inflammatory and produce some structural and functional neuroplasticity. It induces rapid and consistent growth in the dendritic spines, and I'll show you some pictures of this as we go. So here you see the orange line on that first picture that's your left is after a psychedelic-assisted experience, and the psilocybin line is higher, meaning there were more there was a higher density of spines, neuritic connections. And you see that really across the board here with spine density. It just measures the number of dendritic connections. And then this is the figure that I love is, okay, this is your brain right now. Oh, it's okay. That's what your brain's supposed to do. It's supposed to allow you to kind of focus on one thing. It quiets the rest of the mind. But the idea is that the psychedelics allow you to just open it up, right? And so everything's, I don't know if anybody's willing to share an experience, you're welcome to. But what you hear people talk about, if you've ever read How to Change Your Mind by Michael Pollock, he did 4 different experiences with different types of psychedelics. And there are descriptions in there about how you're just aware of every leaf and every bug on a leaf and every blade of grass. And so that's essentially what this default mode network is doing. It's no longer acting as a gatekeeper and everything is allowed to full attention to your brain. Okay, so that's all kind of the backgroundy stuff, kind of like a SSRI in terms of the receptors it works on. Allows your brain to really be open to lots of things. Dendrites seem to be connecting more effectively during that period of time when you're using the psychedelic. And so measures of dendritic kind of density and connectivity are higher. Also, the amygdala seems to respond differently during psychedelic therapy. And in one example, one of the early studies, they said of all the 19 patients who got treated, all of them reported improvements, and then half of them at 5 weeks still reported that their depression symptoms were less. When they look at cerebral blood flow in the temporal cortex and the amygdala, there is a decreased blood flow in the amygdala. So the idea is that maybe the emotional parts are quieting so you can let more kind of data in. So this is that amygdala and the cerebral blood flow. So the idea is that you're actually getting changes in blood flow during the psychedelic experience. So now let's turn to some data. So this is at Hopkins, they actually have done a fair amount with psilocybin. And again, that book is interesting if this is a topic that you want to learn more about, that how to change your mind. And they talk about the history of the programs, and they were kind of cooking along, and then it became illegal and all of them went underground. And so they were all kind of sitting there waiting. And now that there's interest in doing more psychedelic research, all the people have emerged that were doing it 30 years ago. And so they were sort of ready to rock with this when the research became more possible. So at Johns Hopkins, they have this psilocybin research program, and they've treated about 400 patients in over 750 psilocybin sessions. I'm sure it's more now, but they've done everything from cancer to anorexia to depression and dementia, and then substance use disorder and depression. And the way that they do it is, and this is what these healing centers will presumably look like, is you go to a living room setting. So it should be comfortable. A lot of things they talk about in the psychedelic world are set and setting. You need to have an environment that allows you to, benefit from the experience. So being at a loud party, probably not the best. And that's why they're structuring these healing centers the way that they're doing that. So you're in a living room setting, you wear eye shades. This is sort of the ideal. There's some headphones put on with music that suits you. And then ideally you have two guides. There's not interactive psychotherapy, but they give you the tea or the tincture or whatever. And then in about 20 minutes, you'll start to do this substance. It peaks at about 180 minutes and is eliminated after 360 minutes. So this is a whole kind of day process. And you've got two people sitting there with you. So this is high touch stuff, not touch, but high intensity type stuff, right? And the idea is that you'll say, oh my gosh, I'm seeing a scary, monster in the distance. And the psychedelic guides will say, let's go talk to the monster, and so you're supposed to move towards the things that are frightening you. And so they're supposed to kind of help you and process all of that as you're going through the experience. So side effects include, of course, perceptual changes as expected, enhanced emotionality. This can be joy, this can be peace, this can be fear, it can be anxiety, it can be all the above over the course of the experience. Many people will say they have this profound sense of meaning during the experience. And there are often reported increases in mystical and insightful types of experiences. So they have this questionnaire that's called the Mystical Experience Questionnaire, and people will score very high on this after having a psychedelic experience. Now, granted, these are people who agreed to be in a psychedelic study, so they are very apt to have such things. But anyway, the majority of people say psilocybin is the most personally meaningful experience of their entire lives. 80% still meet criteria for significant anxiolytic responses at 4.5 years in several studies. And there are also observed reductions in hopelessness, demoralization, death, anxiety. And actually there's a study at CU right now looking at death anxiety and allowing people with that concern to come and get psilocybin to help with that. So let's go into a little more data. And I'm just going to give you some of kind of the higher profile studies. So this is the one of the Johns Hopkins studies, and this was for patients with cancer-related anxiety and depression. They were aged 21 to 80, and they had a life-threatening cancer diagnosis. So what the primary outcome was clinician-rated measures of depression and anxiety. They had a bunch of other secondary measures. We'll see those here. Yeah, so very strong results in terms of anxiety, reductions in anxiety, both clinical response and symptomatic response. In their first session after the experience and the second session. And even at 6 months, you can see that the majority of people retained improvements in their anxiety symptoms. This is a study that was done at NYU. This was just 29 patients, and it was for cancer-related anxiety and depression, ages 18 to 76. And interestingly, the placebo is really hard to design in these studies because you either have an experience or you don't, right? So what they do is they give people niacin, and so it makes them flush, because that's what niacin does. And the idea is that you'll feel like something's happened, but you won't have the same changes in your brain. So anyway, that's why niacin is the control. And then here again, some of the anxiety and depression measures were the primary outcomes, and then lots of secondary outcomes. And what you'll see here is the blue line is the niacin first. They all got psilocybin eventually, but the purple line is psilocybin first. And this is reductions in anxiety across all of these different tests. And so pretty impressive differences between the two. Yeah, that's basically this similar. Okay. And so then here we have a study that was in the New England Journal in 2022. You worry, well, is this kind of soft science that people are publishing in random journals? But this was actually in the New England Journal in November of 2022. And this was the one that really kind of moved things along. So this was for treatment-resistant major depression. And you had 233 adults who participated in this study, and they got psilocybin or a placebo of some sort. And participants had 25 milligrams of psilocybin or, oh yeah, that's right. The control in this one was less psilocybin. So it was 1 which is thought to not have any effect. So in these individuals, you got the psilocybin plus placebo or, oh yeah, okay, great. And then escitalopram plus placebo. And these are changes in depressive symptoms. And again, significantly less depressive symptoms after having the psychedelic-assisted therapy. And there was an overall incidence of adverse events was really quite similar in both groups. And there was no significant difference between the groups in terms of their some of their depression measures from baseline. Yeah. So here's the different tests. And so basically this top one was their primary outcome measure. And you see how it crosses the dashed line. And so there was no difference. And they said, okay, there was no difference. But yet you look at all these other measures and they all are left of the dashed line, which means they were significantly improved. And so the thought is that no, there wasn't difference on that particular depression measure, but there certainly seems to be a signal for improvement on many, many other measures of anxiety and depression. So finally, where do our people fit in? So the gentleman we started our case study with, 82, has treatment-resistant depression. So does any of this speak to him? And so there was a study that looked at, let's see, this one is safety, tolerability, and pharmacodynamics of low dose. Oh, this was LSD. Let me go to the next one, actually. Let's do this one. So this just came out. This is a systematic review of 36 different studies. The total N across all those studies was 1,400 people, but only 19 of the 400 were over 65. So essentially we have no safety data. We have no efficacy data specifically for the folks that we most often care for. There were no serious adverse events in that group of 10. And they had some, transient anxiety or GI upset. That's pretty common with this particular treatment. Some had hypertension, but we do not have data to support either use of or not use of in our population. So what do we tell this gentleman in your facility who wants to know about psychedelics and whether it could be useful? I will let you take that data and do with it with what you wish, but we really don't have good safety and efficacy data in our older adults. I think the data are beginning to mount for people in younger age groups that there is some hope and that it is pretty enduring, that people 6 months out, a year out are still actually have improved symptoms. So we talked about risks and potential benefits, and we really don't know for our older patients. The mechanisms of action are kind of that ego death, allowing the whole brain to kind of take it all in. There appears to be some anti-inflammatory and some neuroplasticity effects. And the evidence looks encouraging for anxiety and depression, but again, we don't have good data for our folks. And that is all.
Thank you so much. One in the chat box.
Sure,
You
sure.
want to answer one
Sure, yeah.
question? So just talking about the side effects, are treated people allowed to drive after leaving a healing
Oh.
center?
That's a great question. So the healing centers, it's gonna be really interesting. It's not gonna be that profitable probably, right? I mean, you go in, you have your one session and you may be cured, right? So it'll be really interesting to see how this happens. I have the thought that maybe we can have healing centers in our nursing homes. Because then people from the community could come, we can use that extra 20%, you know. it can-
Be available.
Yeah. There you go. And you've got, you know, it's a care center, so there's, you know, anyway. But the answer is you come in and you're supposed to really set aside like 6 hours. And the idea is that you let it sort of, you know, process, metabolize, and that by the time you leave, you're okay. But like an anesthesia, you know, you'd want to have somebody drive you if available. So I don't know if there's specific regulations about that, but probably not a great idea. Probably not a great idea. Do we have time for
Thank
other
you.
questions, or we need to move to our candidates probably?
We do have to move on to our other.
But I'm
agenda
happy
items.
to talk to you.
Evaluation of the operators in this place. I mean, are
Well, that's a huge question.
Yes, yes.
they psychedelic-ized themselves?
Yeah, yeah. Yeah,
Was there any effort to find out what are the basic, are they pretty standardized in their
They're-
approach?
There, in the studies, probably, in the real world, probably not. There is some amount of training that will be required as part of the law. But I think there's a huge variability in that. And yeah, I had some friends that went and did an experience, and it was very different for all three of them, and they had the same facilitator. So it's, anyway.
I just say real quick, not to go full psychedelic, but ketamine, you can either do the full psychedelic or just low dose daily. Low dose daily seems very safe and proven. So I would-
Microdosing.
Yes,
So I couldn't find a lot of data on microdosing. So maybe we have somebody else present. But I've talked to therapists who use microdosing and swear by it in older adults because it's kind of the kinder, gentler approach, but I will stop there.
Oh, thank you so much. Very great information. Appreciate all the data. And I think before we go on to our final segment with the candidates for the board, I think Carrie, did you have some announcement or some requests to make? You're in a perfect place. Yeah, I would stay there.
Good there. So I wanted to, it's actually a different request than what I talked to you about. Okay. What I was hoping to ask about is actually two things. One is if you would like learners in your community where you're caring for older adults, please let me know. Because we have loads and loads of learners who would love to be in long-term care, and we'd love to have them out in long-term care. And the second thing is we have a Geri Care Everywhere program at the university. This is 10 different disciplines: social work, dentistry, occupational therapy, physical therapy, 10 different disciplines, all learning geriatric principles over the course of a year, getting a certificate in geriatrics. And we have slots for 2 more doctors. So if you have somebody in your sphere who's new to this world and would benefit from learning some geriatrics, we know a lot of practitioners are kind of thrown into this environment and they've not had specific training. It's a year-long program. And I can tell you details, but they essentially get a free certificate. It's free now. It won't be in a couple of years, but the state has funded this program and we would love to have them. So take care.
Thank you. Thanks for joining us. Well, thanks for the opportunity, Carrie. All right. Well, so we're going to go into the last section of our meeting. And just so all of you know, after the meeting later today, thank you, Chad, we are going to be sending out ballots to everyone who is a current CMDA member, so you can vote for this election. And I don't think I'll get to it till probably 4 or 5 this afternoon. So if you're not a member yet or you're due for renewal, go ahead and do it now, and we will let you vote for this election. We have 2 positions open for board members at large at CMDA. And we're very pleased to have 2 wonderful candidates. And one of them is here in person. One is going to present by video. And we'll go ahead and give Leia Ginsberg the first slot. Leia and I work together at Optum. She's a DNP
and we're really glad to have you here today.
Thank you. Yeah, so I guess you just wanted a brief little introduction. I've been working in long-term care and some assisted living for 15 years now. Got my start with Dr. Gum actually back at Evercare long time ago. And I did my doctoral thesis on asymptomatic bacteriuria and appropriate antibiotic selection in UTI. So still relevant today, funnily enough, back in 2012. Yeah, and I've always been interested in quality improvement education. I was a clinical advisor for 9 years actually at Optum until just very recently. And that whole job was training new employees, helping them to understand long-term care. You know, what we do is different, obviously, and helping them to understand how to best meet the needs of the complex elders and adults that we care for. So, and then now I'm in a quality improvement position. So this fits right in because I love education. I like working on quality improvement, and yeah, so I'm excited to join a group of like-minded individuals. So thanks.
Thank you, Leah. Appreciate it. With that election. And we're gonna show Dr. Reddy's video, and you think you can't show it. I just realized I could show my video on, but I think only the people on Zoom will see it.
Let me
The
see
people
if
in
I
the room will
can.
not see it.
I'm gonna try.
Okay. Sorry,
Hold
just in
on.
that position. This will be our final announcement from Dr. Reddy.
Hold on. Well.
If we can't, then you might have.
Oh, goodness gracious.
You're doing great.
Keep those bits.
Hold on.
A little faster.
Yeah.
Yeah. So let's see what happens. Okay. Oh, gosh, volume. Oh, goodness.
But I wanted to make sure I made a video to express my interest to join the CMDA board. I highly value the advocacy and the commitment the board has in trying to improve the educational value to the nursing home world, to improve the patient's day-to-day lives. That's one thing that has drawn me to the beginnings of the CMDA, interested in joining the board. I'm honored that I'm even being considered to join the board as well. A little bit about me, for anyone that hasn't known me yet. I work for a company called Summit Medical Consultants. I've been working for them since 2018. I'm a multi-facility medical director as well. I also feel passionate about increasing the knowledge base and providing the tools to nursing homes to care for residents in a better way. There's a lot of struggles in this field already, and a lot of stresses, and I just want to be there to align with your guys' values as well and provide increased education to where it's needed the most. With upbringing being Indian as well, we're family-oriented people that has drawn me to be passionate about this field. So hopefully you guys can consider me to join the board. I'd be more than honored to join and be an active participant for anything you guys need. I hope you have the rest of your meetings going well, and hope to be part of this group here in the near future.
Great. We really appreciate Leslie being our tech person today. And drink, Alyssa and Allison helped supply everything. Thank you all for joining us today.
Thank you. Beautiful.
Thank you.
Yes.
Good to get back.
Hi, Greg.
Yeah, I will.
That was it. There you go.